share my
Teacher,
screen with you. Inshallah, inshallah. So we will learn together about deep neck space infections. What are these spaces? How the patient presents, and what are the lines of management of these infections? We will discuss three common causes or types of deep neck space infection. First is peritonsillar space infection. Second is parapharyngeal space, and third is retropharyngeal space. So what is the peritonsillar space from anatomical point of view? This space is found adjacent to the tonsil. It is bounded by the capsule of the palatine tonsil medially. It is bound by the palatine tonsil, so it is part of the oropharynx. And laterally, it is bounded by the superior pharyngeal constrictor. It is lined superiorly and inferiorly by the anterior and posterior tonsillar pillars. So this is the peritonsillar space, the yellow color. Peritonsillar abscess is a collection of pus between the fibrous capsule of the tonsil, usually at the upper pole of the tonsil, and the superior constrictor muscle of the pharynx. So when looking for the, suppose for the tonsil from the oropharynx, it is the superior lateral part of the tonsil. It usually arises as a complication of tonsillitis. It usually happens at any age, but clinically most commonly in young adults between 20 and 30 years of age. So a disease of a young patient. Usually deep neck space infection in commonly there are mixture of microorganisms, what's called polymicrobial microorganism. Usually anaerobic organisms are involved, beta hemolytic streptococcal and methicillin resistant staphylococcus aureus, also identified in peritonsillar abscess. What are the clinical representation of patient with peritonsillar abscess? Besides, there is a history of recurrent tonsillitis, very important, usually patient presented with one side or unilateral progressive sore throat. Over a few days, there will be severe odynophagia, painful swallowing, dysphagia for solid, and may progress even for liquid, and even for his own saliva, was called obsolete dysphagia. And you know that dysphagia may lead to dehydration and poor oral intake. Trismus is a very important manifestation of peritonsillar abscess, inability to open the mouth. We usually open the mouth by 3-finger breadth. Yani the distance from the lower jaw to the upper jaw, clinically we can widen to 3-finger breadth. Patient cannot open even to 1-finger breadth. Trismus is due to an inflammation and irritation of the pterygoid muscle. Ipsilateral otalgia and headache associated with fever, lethargy, extremely tender unilateral or ipsilateral lymphadenopathy, cervical lymphadenopathy. The patient usually have voice changes, but not hoarseness of voice because the larynx is not involved, but have a blummy voice or hot potato speech, secondary to oropharyngeal swelling. when you face a patient with peritonsil abscess, the first feature that make the physician or the clinician think about peritonsil abscess, when he asks the patient to open his mouth, he cannot open his mouth adequately. So trismus. Second, tonsil is displaced medially, and the tonsil is neither normal and never normal. The tonsil is never normal. The tonsil is displaced medially by the hyperemic bulging mucosa of the anterior pillar over the peritonsillar space. The uvula is also deviated to the other side, and the condition is usually unilateral. I never see a bilateral quinsy. I don't know if it is mentioned in the literature. I didn't search for that. Jugulogastric node are tender and enlarged. This is a picture showing a huge inflammatory edema and swelling above and superior to the tonsil, with pushing the tonsil, edema of the soft palate, and pushing to the other side. Bulging of the soft palate in peritonsil abscess, and this is the unilateral peritonsil abscess. You have to differentiate from whether it is peritonsillar cellulitis or abscess. Tapping of the area and aspiration can differentiate. Imaging study can differentiate whether there is abscess formation or there is just cellulitis, because cellulitis you can start conservative treatment, while the abscess you have to drain the abscess as early as possible. Parapharyngeal abscess should be differentiated, although the feature of parapharyngeal abscess can differ from peritonsil abscess, as we will learn together later on in this presentation. But one abscess can lead to infection of the another space, because the infection, as you know, infection will not respect the boundaries, our anatomical boundaries. So there might be interconnection between deep neck space infections, and one infection can extend to another one. Post-traumatic internal carotid artery aneurysm or pseudoaneurysm can cause confusion, especially in elderly. A tumor in this area also can lead to confusion, but there is a characteristic history. There is no fever, there is no sore throat, and the history is usually longer. Any pulsating mass in this area, you have to be very cautious and suspect a vascular lesion. Tumor in this area, like benign lymphoepithelial cyst, as we discussed, the longer duration in history. Neoplastic, usually it is primarily a primary tonsillar pathology, the tonsil, not the peritonsillar area. Large tonsillar tumor with lateral extratonsillar spread, such as squamous cell carcinoma, usually longer duration. The picture is usually differ. The characteristic picture, as you see, there is ulcerative lesion of the tonsil, and the lymph node differ. The lymph node in case of neoplastic are usually hard, not tender, like in an inflammatory condition. Investigation is not mandatory in clear-cut cases, but in less straightforward cases, usually, especially when there is poor condition of the patient or severe condition of the patient, you have to investigate. When you suspect extension of the abscess beyond the normal confinement of the peritonsil abscess, you need to more investigate the patient. When you suspect more than one space involvement, especially in diabetic and immunocompromised and AIDS patient, needle aspiration of the pus is also helpful in diagnosis to confirm the abscess formation, because when you aspirate the pus, there is abscess formation differentiated from cellulitis. early stage of inflammation, and also important for culture and sensitivity. Transoral ultrasound is also helpful. CT scan is the imaging study of choice in case of deep neck space infection in general, usually with contrast. Will show us this picture showing you a hypodense area with rim of enhancement. This is a characteristic feature of deep neck space abscess formation. MRI angiography may be suitable for suspected vascular anomalies when you come across a pulsating mass in the pharynx. Peritonsillar abscess treated as inpatient, and admission to the hospital is mandatory for follow-up with intravenous antibiotic and also close observation for any possible complication. Drainage either by needle aspiration or by incision and drainage. Needle aspiration for a small abscess, incision and drainage transoral under local anesthesia, transoral on the most prominent part of the abscess. Indication of surgery, clinical deterioration, or patient presented with frank pus formation on CT scan or on immediate aspiration, failure to respond to intravenous antibiotics, evidence of pus of peritonsillar based on imaging modalities. Is there any option to address the tonsil? Because the tonsillitis is the underlying mechanism. We recommend not doing a hot tonsillectomy at time of abscess drainage because there is a risk for bleeding post-operative. So the usual policy is to do elective tonsillectomy. After recurrent quinsy is recommended after 6 to 8 weeks. You schedule your patient for tonsillectomy after a few weeks. طبعا recurrent twice quinsy is an absolute indication for tonsillectomy. When a quinsy with recurrent attack of tonsillitis is also an indication for tonsillectomy. What is the most important complication of deep neck space infection? Please concentrate on this area, on this question. The most important and the most significant complication of deep neck space infection in general is airway obstruction. So when you face a case of deep neck space infection, you are a resident, you have to pay attention to the airway. You have to pay attention to the airway. Other complication due to mediastinitis with significant mortality. This is your tracking of infection. Necrotizing fasciitis, especially in immune compromise, when the soft tissue of the chest or the neck get necrosed with foul smelling and also with great mortality. Any question regarding peritonsillar abscess? Any question?
دكتور نعم سؤال.
تفضل.
Trismus occurs because of pain or because of inability to open up the mouth?
No, because of both. Because of pain, because it is painful, and because of irritation and inflammation of the spasm, irritative spasm of the pterygoid muscle. Okay.
نعم دكتور. زين دكتور أنا شلون أقدر أفتح الماوث مالت البيشنت إذا هو ما يقدر؟
with difficulty. Yes. هو طبعا أنت ما تفتح شيء، هو يفتح المريض، ماكو forceful opening. بس الفكرة إنه open with difficulty, very difficult, and you don't expect a full range of movement. طبعا I agree with you. It will be difficult for the examiner, it will be difficult for the intervention, but with good communication, with good communication with the patient, you can get adequate opening. but usually with pain. Okay. نعم.
اوكي دكتور نعم.
Okay. Okay.
بعدين دكتور
I want just to نعم مريم.
بس على الإلكتيف تونسيلكتومي لأن يعني الوقت يعني شو وقت تكون يعني مسموحة شو وقت لا ممكن يعني توضيح.
هو elective مذكورة بالمحاضرة يعني about 6 weeks 6 to 8 weeks. يعني انت معالجة البيريتونسل ابسس وصارت امور المريض زينة، تقول لي يابا انت ورا 6 اسابيع يعني better to do tonsillectomy counsel about possibility of tonsillectomy. ماشي؟ نعم.
وقت تكون كونترا انديكيت دكتور، قلنا إذا ما في سك إذا كانت
إذا early لا ما تسوي له tonsillectomy at time of surgery at time of infection should be postponed. نعم.
نعم.
حشتيدك. أنا بس نقطة راح أذكرها، خليها بالبارافارنجال سبيس نذكرها على مود الوقت. Okay. The second topic is parapharyngeal space. From its name, lies on either side of the superior part of the pharynx. It is bounded by laterally by the parotid gland, parotid fascia, and medial pterygoid muscle. Medially, it is bounded by the superior constrictor muscles, يعني the pharyngeal wall. It is beside the pharyngeal wall. Superiorly, it extends to the skull base, limited by the skull base, and inferiorly by the fascia surrounding the submandibular gland. So it is an inverted cone shape with a wider base and narrow apex. Very important anatomical fact, the space communicate with retropharyngeal space. So it's يعني infection from one space can extend to another, as we see, and also it communicate with submandibular space, with other, even peritonsillar space can communicated by or can interconnect with each other. Further, anatomically speaking, the parapharyngeal space is divided into 2 compartments, either pre-styloid or post-styloid. Pre-styloid means in front of the styloid process. It is a it's a muscular compartment. It's bounded by the tonsillar fossa medially. This is the green compartment. Tonsillar fossa medially, pterygoid muscle laterally, medial pterygoid muscle laterally, and it contains fat and connective tissue and lymph node. While post-styloid compartment of the parapharyngeal, the blue compartment contain more neurovascular compartment, carotid sheath, the lower cranial nerves, and sympathetic chain. Why this classification is important? Because a tumor in this area, like schwannoma of the carotid sheath or carotid body tumor, may give rise to differential diagnosis of parapharyngeal space swelling. What are the causes of parapharyngeal space which can occur at any age group? It may complicate tonsillitis, maybe an extension of peritonsillar abscess, maybe an infection from the teeth or gums, and rarely it follow elective tonsillectomy. May follow mastoiditis due to extension of infection. Even may patient have a history of foreign body, trauma from nasotracheal intubation, internal cyst and fistula of bronchial origin or second pharyngeal pouches. As we said, infection will not respect our anatomical boundaries And one infection may complicate by infection of other spaces. For example, spread to the parapharyngeal space from any other deep neck space like peritonsillar. This is a peritonsillar extend to the parapharyngeal, or from submandibular to parapharyngeal. And look how much the retropharyngeal space is close to the parapharyngeal space. And how you can differentiate? By adequate radiological assessment. Causative agent, Klebsiella pneumoniae, Streptococcus viridans, and Pseudomonas aeruginosa, especially in patients with diabetic and HIV diseases, AIDS. Clinical features are similar to peritonsillar abscess because there is pharyngeal swelling, but the maximum swelling in the pharynx is more inferiorly placed and behind the tonsil with less edema of the palate. Less edema of the palate. And the differentiating point, there is another swelling in the neck. There is another swelling in the neck, which is tender, firm, but fluctuant swelling of the abscess to be felt in the neck, rather than just lymphadenopathy. This is how to differentiate. It has a cervical extension rather than a purely, transoral or oral extension. Differential diagnosis: peritonsillar abscess, spinal TB. You have to then from neoplastic, like primary tumor of the parapharyngeal space, as we said, from deep lobe of the parotid, or local spread from the tonsil, or maybe a lymphoma. All these you have to differentiate between. All these are local infection, local signs and symptoms of infection are absent. طبعا adequate radiological investigation also important in this case. This is a case of hypodense area with rim of enhancement, characteristically of parapharyngeal abscess formation. Pseudoaneurysm is also a differential diagnosis. Imaging study, carotid angiography helpful in this diagnosis. How to investigate a patient with parapharyngeal space infection. I want to concentrate on one point. أنا قلت لكم راح أذكر لكم إياها هي تنطبق على جميع الديب نيك سبيس infection. The golden rule: never investigate a patient who his or her airway is unstable. Don't send patient for radiological imaging unless you are sure it is a stable patient regarding the airway and to a lesser extent the hemodynamic state of the patient. Because during transfer from emergency or during the ward نردها أو من الطوارئ to the radiological department, you might lose the patient. So you have to be sure his airway is adequate. You have to be accompanied by expert person, health personnel like a doctor or resident. Okay, with prior communication and arrangement with radiological department. Never send a patient whose airway is compromised because there is a risk for losing the patient. If you have a portable imaging, if you have a near radiological department, and or the patient is stable, plain X-ray is helpful. Bilateral view of soft tissue of the neck can demonstrate foreign body penetration, for example. CT scan and MRI of the head and neck if mastoiditis is suspected, and CT scan involvement of the chest. CT is also important because to exclude or to confirm a complication of paratonsillar or parapharyngeal space infection. This is an MRI of the deep neck space infection. How you treat a parapharyngeal space infection? By admission to hospital for because there is a risk of upper airway obstruction. You have to admit the patient for intravenous antibiotic, for monitoring of the vital signs and state of the airway. Intravenous antibiotic cover the aerobic and anaerobic microorganism by third generation cephalosporin, with metronidazole. You keep the patient on observation. If the patient has just cellulitis and he is doing well, the airway is not compromised, you can keep him on conservative treatment. Failure to respond to conservative treatment, still the symptom is present, or a clinical deterioration, should prompt surgical abscess drainage or abscess diagnosed from radiological investigation from the start is also an indication for surgical drainage. Traditional site of drainage is through an incision on the side of the neck at the level of the hyoid bone, and differ from the incision and drainage of the peritonsil abscess. Peritonsil abscess is transoral, while here is transcervical. Transcervical, usually under GA, under general anesthesia, while transoral can be done under local anesthesia. Complications of paratonsil abscess, parapharyngeal abscess, carotid sheath involvement. The most important is upper airway obstruction. The most important and the most critical, and you have to keep in mind, is upper airway obstruction. Other like carotid sheath involvement, acute pharyngeal perforation secondary to cervical necrotizing fasciitis, mediastinitis, and descending necrotizing fasciitis of the neck and mediastinum. Any question, please, regarding the parapharyngeal space infection?
Doctor, I have a question about the uvula. Is the
Yes.
uvula deviated in either the parapharyngeal or the paratonsillar abscesses?
Yes, it is both of them. It is deviated. Any mass pushing the parapharyngeal compartment, the lateral wall of the pharynx, any pathology involving the lateral compartment of the pharynx, it will push the midline structure to the opposite side. This is a rule. It is usually well differentiated by how to differentiate parapharyngeal from peritonsillar. Presence of cervical swelling. Second, in peritonsil abscess, usually it is confined to the oropharyngeal area. Imaging study is also helpful for you to differentiate more extensive parapharyngeal space involvement. Okay. The most critical point from my knowledge is to when you face a peritonsil abscess, the first question, is this abscess confined to the peritonsillar, or it is complicated by parapharyngeal space? This is the most important question, because when you face a case of parapharyngeal space, diagnosis or exclusion of peritonsil abscess is of less significance, because one may complicate other. But when you face a case of peritonsil abscess, you have to ask yourself, my patient is only peritonsil abscess or may have another deep neck space infection? You check the point, you guess the point, Ja'far? دائما احنا we exclude the most serious. يعني انت من يجيك مريض عنده peritonsillar، انت هذا peritonsillar only peritonsillar، لو عنده another space infection. او زين اجاك بارافارنجيال، هذا بس بارافارنجيال. لو اني ادز سيتي واخابر الراديولوجيست، اقول له علي كريم راديولوجيست، اقول له دكتور علي check this point, this patient may have extend to the mediastinum or to the lower chest. دائما احنا we check for extent of the pathology. ماشي؟ we exclude the most serious thing. نعم.
I have another question, if I may.
You can leave the question for the end of the lecture because we
Okay.
have to go. Yes, just I want to show you another point. Why it is at the level of the hyoid? Why the drainage of the abscess at the level of the hyoid? This is a question for you, and I want your answer from the chat. I will review at the end of the. فكروا بيناتكم ليش الانسجن مال يعني الابسس درينج بالبارافارنجيال should be at the level of the hyoid bone. لا حد يجاوب هسه، جاوبوني على الشات at the end of the lecture. Retropharyngeal space is very important space. من اسمه retropharyngeal, it means behind the pharynx. Parapharyngeal, beside the pharynx. Retropharyngeal, behind the pharynx. It is bounded, the red color, anteriorly by the pharynx and oesophagus, or the buccopharyngeal fascia overlying these structures. Posteriorly by the alar layer of deep cervical fascia. Alar layer of deep cervical fascia. هذا الجزء. Superior border it extends from the skull base, and inferior border extends to the superior mediastinum. Look how much it's long, how much the infection may separate from the base of the skull down to the mediastinum. Mediastinum is a part of the, يعني it can reach to the superior mediastinum. Midline raphe connect the superior constrictor to the deep cervical fascia. It makes the retropharyngeal space into two partitioning, right and left. What are the content of the retropharyngeal space? Is lymph node, and this lymph node usually involute by the age of 5, lymph node of Rover, and this lymph node in infancy and young children may get inflamed, suppurate, and lead to abscess formation. So it is more common in young children, and it may complicate upper respiratory tract infection. It is most commonly in children under 6 years of age, with peak incidence between 3 and 5 years due to suppuration of the retropharyngeal lymph node, اللي قلنا عليها lymph node of Rover, following upper respiratory tract infection. In adult and children, it may occur very rarely secondary to foreign body penetration. Tuberculous retropharyngeal abscess is rare, even in the presence of a tuberculous cervical spondylitis. Causative microorganism as Streptococcus viridans was the most common. Staph epidermidis, Staph aureus, penicillin-resistant Streptococcus pneumoniae have been described as a causative microorganism in pediatric cases. Anaerobic microorganism, usually it is polymicrobial. It is polymicrobial in etiology. What are the presentation of patient with retropharyngeal space infection? There will be neck stiffness associated with fever, irritability, and dysphagia, with high incidence of upper airway obstruction, and the patient may be presented with either stable airway or compromised airway with stridor. But you have to keep this in your mind. The most common and the most important complication is airway obstruction. Neck stiffness, the patient usually presented with torticollis. What is torticollis? Is spasmodic posture of the neck, the patient cannot move his neck يعني freely, and because there is as the trismus due to irritation of the pterygoid muscle, here irritation of the neck muscles. So the patient present with an inclination of the neck is called torticollis. Oropharyngeal examination, you have to concentrate on the posterior pharyngeal wall. You will see posterior pharyngeal wall bulge, and usually it is on one side because there is a raphe. There is a partitioning between the right and left retropharyngeal space. Diagnosis of retropharyngeal space in infant and young children can be easily overlooked because the patient presented with irritation, fever, and we will not look to the oropharynx and should not, maybe missed. And even it's entered in differential may consider the patient as a CNS case. Actually, it is a localized infection of the retropharyngeal space. History of previous TB contact or pharyngeal trauma by fish bone or chicken bone must be specifically sought. Even history of intubation, for example, or even surgery that require intubation. Pain occur at relatively late stage and may be associated with fever. Neurological signs may develop due to cord compression and maybe bulging of the posterior pharyngeal wall on examination. Differential diagnosis, localized tumor in this area, like nasopharyngeal carcinoma, usually in adult. Lipoma, usually there is no signs and symptom of infection. Malignant schwannoma is also there is no sign of and symptom of infection. Sarcoidosis and schwannoma, radiological diagnosis are helpful. Apparent internal carotid artery mass may be presented with pulsation of the pulsating mass. Imaging study with MRI angiography is helpful. Internal carotid artery aneurysm and hematoma also. MRI with imaging study, MRI angiography is also helpful. Plain lateral film and flexion and extension show loss of normal curvature of the cervical spine with soft tissue bulge in the front of it as well as bone destruction. In case of a tuberculous spine, maybe see a bone destruction. Normally, normal person, the cervical spine is normally lordotic. What we mean by lordotic is anteriorly convex. Convex anteriorly and concave posteriorly. يسمونه lordosis يعني مثل مشية اللوردات الإنجليز من يمشي has a belly or abdomen in front of him. They are obese. والabdomen well distended abdomen يسمى lordotic view أو lordosis. Normally lordotic. Retropharyngeal abscess, what there is straightening of the spine due to spasm, straightening of the spine, and this another picture B, there is widening of the retropharyngeal space. This is the soft tissue, which is normally not more than 2/3 of the corresponding vertebra. It will be discussed in more detail with Dr. Ahmed, inshallah, in the discussion about radiology in ENT and online teaching session. هاي أيضا صورة ثانية للretropharyngeal infection with widening of the pre-vertebral soft tissue. قلنا احنا الجولد ستاندرد هو السيتي سكان with contrast. CT scan with contrast study. Treatment is by surgical drainage is the norm in pediatric because the airway is compromised So you have to be interfere as early as possible because of significant incidence of airway compromisation in about 30%. General anesthesia is advisable but require great skill, and the abscess is incised through the pharyngeal wall transorally and bus sent for bacteriological examination. But good collaboration between the ENT surgeon and the anesthetist is important to achieve safe surgery. Mediastinitis, spinal epidural abscess, osteomyelitis of the odontoid process, and virulent meningitis has been described as a complication of adult retropharyngeal airway. Again and again, you have to consider upper airway obstruction is the most important and the most significant complication following deep neck space infection. Any question? Please, any question? Dear students?
Doctor, what is the meaning of tonsillar prolapse? I read about it as a clinical feature for parapharyngeal abscess.
Tonsillar prolapse?
Yes.
Yes. Actually, I didn't hear about this term. I think it is an Indian book. شوي Indian books فيها some يعني exceptional terminology. Is it an Indian book?
Well, I'm not sure.
Maybe an article written by Indian author. I didn't hear about this, but from the name, I guess it is just a displacement. You know, any prolapse means displacement. It means displacement of the tonsil. Okay? Okay, Ja'far?
تمام دكتور تمام واضح.
Okay. Now we look for the chat. What are your answer about my question? I think no answer in the chat. Just two answers. Where is the rest of the students? جعفر يقول middle and superior. لا احنا قلنا هو سؤالنا ليش الانسجن at the lower part of the at the level of the hyoid.
Doctor, I think because
منتظر انت
Doctor can answer or
اي جاوب مو مشكلة احمد جاوب you can. Yes.
Doctor, I can because to be the drainage by gravity.
By gravity. اوكي هنا انا هم محمد امين يقول by gravity to avoid important structures.
Avoid injury to neurovascular يعني.
Yes. Or even in this level you have to avoid injury. Even in any level you have to avoid injury, but of course it is neck surgery is not an easy job. There are dangerous vital structures. You are right, but it is because it is the most dependent part, as Dr. Muhammad Amin said. It is the most dependent because it will not leave a cavity behind. All the cavity will be drained to the outside. Okay, because it's the most dependent part.
Doctor, do we put the drain?
Yes, of course, we put a corrugated drain following any abscess drainage. Yes, because you never guarantee cleaning of the area, and because the infection is still ongoing, so you anticipate further formation of the pus material, but usually will be settled by continuous treatment. Of course, you have to continue on your medical treatment. So my question for you, what are the benefit of Oh, let's before that, what is the gold standard imaging study in deep neck space infection? What is the imaging study, the gold standard imaging technique?
CT scan.
CT scan.
MRI.
CT scan. CT scan is more gold standard, more than the MRI. CT scan. With contrast or without contrast?
With contrast.
With doctor.
Why you advise for, you ask for with contrast material? Why?
Firstly, to identify the vascular structures so as not to miss them, and secondly, to enhance the rim and the outer rim of the abscess.
Yes, of course. Okay, what are the benefits? What are the information you can get from the CT scan of the يعني imaging study؟ بس غير جعفر نشوف أفراح أو مريم، إذا جاوبنا أفراح أو مريم. What are the information you gained from CT scan? What you are looking for in the CT scan? مريم، أفراح.
نعم دكتور، يعني CT scan يعني سوينا يعني soft tissue extension involvement of the bone.
أول شيء pathology. أول شيء confirmation of the diagnosis. Confirmation of the pathology. Very good. بعد شنو؟
يعني أنا بدي information نشوف يعني other extension مثلا involvement of others.
الاكستنت بالضبط، يعني هذا السبيس only when there is space or involve other or involve another، يعني مثلا intestinum chest. So extent of the pathology. بعد وأيضا differentiate between cellulitis and abscess. cellulitis and abscess، لأن تعرفين إذا عندنا مريض just cellulitis حتى لو deep seated cellulitis والمريض هو يعني stable، الايروي مالته stable، وهو المريض cellulitis، يعني فور اكزامبل بارافارنجال cellulitis وماكو ابسس. مثلا حكيت ويا جعفر، مثلا جعفر راديولوجيست، دكتور جعفر طمأنك انه دكتور افراح هذا مريضك just cellulitis ماكو ابسس فورميشن. قال لي لا اوكي، والمريض يعني looks is not deteriorating، نبدي conservative treatment ماشي. بينما اذا قال لك دكتور جعفر لا، قال لك دكتور افراح هذا مريضك بين عنده well localized abscess، فهنا نفكر بمن؟ بالسيرجيكال درينج، مو صحيح؟ لان اكو رول when there is an abscess you have to drain. when there is an abscess let it out you have to drain. بالضبط. فاول شيء فرق لنا بين السيلولايتس والابسس، يسوي لنا confirmation للدايجنوزز و extent of the pathology. extent of the pathology. اكو سؤال بابا؟ اكو سؤال؟
دكتور عفوا، اكو اتش ام سي كيو وين بنهاية المحاضرة؟ ام سي كيوات 2 ما ادري موجودة بالنسخة اللي عندكم لو بس اللي عندنا؟
لا ما موجودة عندي. لا ما موجودة عندي. ما موجودة عندي. لا هو هاي المحاضرة ما هذا بعد. لا بس هاي المحاضرة.
دكتور ما هو الام سي كيو مكتوب به the most common site of quinsy is R superior to tonsil, lateral to tonsil, posterior to tonsils, inferior to tonsils وميديال to tonsil.
لا هو بصراحة هاي المحاضرة بس المحاضرة هذه يعني لا يعني أنا بصراحة النسخة عندي هاي، لأن هي المحاضرة أيضا كان ينطي دكتور فراس، وبعدين العفو أستاذنا دكتور ياسر ودكتور فراس حاصل صار يعني ري ارينجمنت بالمحاضرات. أنا جتي هاي احتمال هاي بالنسخة القديمة عند دكتور فراس هاي الام سي كيو. ماشي؟
نعم دكتور.
يعني أنا مفارق تقريبا 2 أو 3 سنوات بدون الام سي كيو. عموما هي يعني good chance for learning، ماكو مشكلة، يعني أسئلة لطيفة. اي نعم. تريد تناقش بها يعني؟
لا هو دكتور بس تسأل، يعني هو الكوينزي بالعادة يصير بالنسبة للتونسل، يعني الكومن سايت سوبيريور لاترال الها لو انفيريور لو، هو حسب الام سي كيو. يعني
انت شو تقول؟ موجودة بالمحاضرة. انت شو تقول؟ علي
دكتور مو سوبيريور؟
لا مو هو يعني احمد احمد انت
إيه
يعني
دكتور، انا امس قلت في بالي
ساعدك
شوف
ساعدك احمد، ساعدك احمد. يلا هي ديسكشن. لا هو السوبيريور مثل ما قال احمد، هو قاعد above the superior ball of the tonsil. اي ماكو مشكله. اوكي
نعم دكتور.
انا اعتقد اترككم شويه تاخذون ريست قبل المحاضره. هذا الريست يعني هو شو نسوي به؟ شويه ريفرشمنت للبرين، لازم ناخذ ريست فور اور نيورون يعني. وانتم ايش ما يقدرون يسوون به العشر دقائق، بس يعني واحد يغير مكانه شويه، يتحرك، يقوم، يقعد، وينطي ريست للبرين. شكرا جزيلا، شكرا جزيلا
نعم دكتور، عاشيكم، شكرا جزيلا دكتور
شكرا
زكي.
جزيلا دكتور علي، دكتور
دكتور
جعفر،
حمدان، دكتور منوني.
احمد الصافي. شكرا لجميع الافراح والمريم والاسراء، وشكرا لجميع الطلبه. نلتقيكم ان شاء الله يوم الثلاثاء ان شاء الله. ان شاء الله اشتريكم. مع
ان
السلامه.
شاء الله دكتور، في امان الله.
ممنونين دكتور، مع السلامة.
السلام.